So I want to welcome all of you to the Alfred A. Strauss Visiting Professorship and Lecture, the 73rd year of the Alfred A. Strauss Visiting Professorship. And I want to start off by introducing our interim Dean of the University of Washington School of Medicine and CEO of UW Medicine, Dr. Tim Dellett, to introduce the
Well, thank you. Thank you very much, Doug, and welcome everyone here. It's an honor and privilege to be with you here this afternoon as we really celebrate and remember Dr. Strauss, an individual who is not only a pioneer within surgery, but really played a founding role in the establishment of our school. And quite frankly, one of the reasons why we're all here and able to gather this afternoon. Now, I'm presenting the 73rd Annual Strauss Lecture. The Strauss-Friedlander family is carrying on the tradition established so many years ago by Dr. and Mrs. Alfred A. Strauss. Born in Germany in 1881, Dr. Strauss came to Colville, Washington at an age of 10. An honor graduate of the University of Washington in 1904 and an outstanding member of the Alumni Association, received the singular honor of Alumnus Summa Laude Dignatus in 1951. Now, Dr. Strauss was a football and baseball star as an undergrad. As an alumnus, he was active in the recruitment and establishment of scholarships for athletes at the University of Washington. In fact, he recruited 75 individuals from the Chicago area to come and play football at the University of Washington, 5 of whom became All-Americans. In 1981, he was elected to the Husky Hall of Fame. Dr. Strauss received his degree from the Rush University of Chicago Medical School in 1908, graduating first in his class. He interned for 2 years at Michael Reese Hospital in Chicago, completed a brief surgical fellowship under Professor Erdlinden in Heidelberg, Germany. He then returned to Chicago, where he spent his professional career. Dr. Strauss possessed a rare combination of skill, vision, and drive, and was intimately involved in many of the first in the advance of medicine, including refinements of pyloroplasty, subtotal gastrectomy for peptic ulcer disease, surgical advancements for inflammatory bowel disease, and the first description of an abdominal wall zipper to facilitate frequent re-explorations. Dr. Strauss and his 2 physician brothers, Herman and Siegfried, also University of Washington undergraduate alumni, founded Weiss Memorial Hospital in 1953 in Chicago. Dr. Alfred Strauss is also well remembered for his influence in founding medicine here at the University of Washington. On July 22nd, 1944, Dr. Strauss, as a member of the proposed medical school committee, met with Governor Langley, strongly advocating for state funding for a new medical school. An appropriation bill was signed by the governor on March 15th, 1945. Soon after, in the fall of 1946, we welcomed our first medical school class here at the University of Washington. True to his continued institution, Dr. Strauss sponsored a surgical lectureship in 1950 for the Department of Surgery, and these lectures have been a prestigious annual event ever since. Today's program is supported by the Alfred A. Strauss Endowed Lectureship in Surgery, established by the estate of Mrs. Marjorie Friedlander, daughter of Dr. Strauss, and annually supported by generous contributions from Dr. Strauss's nephew, Dr. John Strauss. We are fortunate to have Dr. Strauss and John Friedlander, the son of Marjorie Friedlander, of Dr. Alfred Strauss, with here today to celebrate with us. And again, thank you very much for joining us here this afternoon. And again, it's a real honor to be here, again, to celebrate this pioneer in surgery and one of the individuals who helped found our own school. So thank you.
So I'm actually going to go through a couple of the slides that so that you could see Dr. Strauss, because I was trying to advance them for Dr. Dellett when he was presenting, but not able to. So you can see the athletic accomplishments that Dr. Dellett was talking about, his important role in surgery and in being a founder of the Weiss Memorial Hospital, and the multiple accomplishments that he surgery and in United States medicine, and this being the first lecture of the Alfred A. Strauss visiting professorship. And I want to show the photo of Dr. John Strauss and John Friedlander, who are very dear friends that we get to see at least once a year, except for the past 3, and who we really appreciate for your ongoing support, both of you. The visiting professorship, and for the time that we have to honor your uncle and grandfather. And for those of you that go by the Department of Surgery, I welcome you to just stop in just inside the door. We've got this marvelous painting of Alfred A. Strauss just inside the door of the Department of Surgery, honoring a prominent role, like the prominent role that he's had in American surgery. So when we invite a visiting professor for this, we want somebody who's also prominent, and we couldn't have found somebody better than Dr. Jeffrey Matthews, who's the Dallas B. Phemister Professor and Chair of the Department of Surgery at the University of Chicago. And it turns out that there are 2 Strauss lectures, one at the University of Washington that we're all here for today, and the other one's at the University of Chicago, which will be next week. And Dr. Matthews side of this next week, hosting the Strauss professorship at the University of Chicago. So when we look at the accomplishments of Dr. Matthews, we can affectionately note that he's preparation H. I say that with all affection, as you know. Someone who's gone to Harvard College, then to Harvard Medical School, then did a residency in general surgery at Harvard, and then he faculty at Harvard. So it's especially obnoxious to the rest of the world to see that. But I wanted to call it out and say that it was only interrupted by a hepatobiliary fellowship at the University of Bern. So on faculty at Harvard, Dr. Matthews, within 3 years, was promoted to associate professor. Those of you that are assistant professors are going, wait a minute, how does that? That's very difficult to accomplish. He was then recruited to the University of Cincinnati as chair of the Department of Surgery at the University of Cincinnati, just 9 years after finishing his training. And 5 years after that, in 2006, he was recruited to his current position as chair of surgery at the University of Chicago. We heard this morning a little bit about Dr. Matthews' areas of expertise. He's a surgeon and really a world leader in pancreatitis, a world leader in complex hepatobiliary surgery. One of the handful of surgeons involved in islet transplantation for those with chronic pancreatitis, and major experience in bile duct reconstruction and complex gastrointestinal surgery. He's the type of person that's been a president of many organizations, the Chicago Surgical, the Society of Surgical Chairs, the Society for Surgery, and the Society of University Surgeons. Been a director of the American Board of Surgery, the chair of the ACGME Residency Review Committee for Surgery. His education commitments and achievements have been recognized as a member of the Master of Surgeon Educators. Been on multiple editorial boards, editor-in-chief of the Journal of Gastroenterology, and one of the co-editors of Schwartz's Principle of Surgery, which many of us have read. He's been very involved in DEI work. In fact, he's been long an honorary member of the Society of Black Academic Surgeons, And just 3 years ago, he was recognized at the University of Chicago as a distinguished leader in diversity and inclusion from University of Chicago Medicine. He's been academically prolific with over 200 publications. So those are all the accolades, but there's more. Dr. Matthews is a Renaissance man. So most of you must follow him because he has over 27,000 followers on Twitter. So he's got a major presence on Twitter. And if you look at this, you can see that docs who rock, dad jokes, bad sport takes, the things that represent him. He's also now a Peloton chair. So this is him after a Peloton workout, but he's not just a Peloton chair and one of the members of chairs who do Peloton, but also, and there's lots of times that he's running on the Chicago waterfront, and as a family man, this shows him with his wife, Joan, and the beloved puppy, Archie. Also has 3 sons who I think are at least as equally loved as Archie, but Archie is high up there. He's a chef, a breakfast chef. I think this is blueberry pancakes, but I found out that he also hosts a competition at the Department of University of Chicago, the Iron Chef competition. Is this the Iron Chef competition in your kitchen? Yeah, that's what I thought that it was. So we have a new idea for us as a community event in the Department of Surgery. Finish with the aspect that most of us have careers of being a surgeon because that's all we could do. Actually, Dr. Matthews is a secret rock star, and here he is in the recording studio. He knows way too many real rock stars, and this is as he's doing his mix of his most recent album, Shut Up and Listen. That's the lead track from Shut Up and Listen. So I encourage you to go. There is a Spotify channel, Jeff Matthews, so you can download and listen to the whole take. And he has you said you have another one in the works. You're going to be in the studio soon. Dr. Matthews is somebody who's a visionary surgeon, someone that we all look up to, and who is someone that I think the residents and other faculty see as a role model, that others plus chairs see as a role model. So we're particularly happy to have you here as our 73rd annual Alfred A. Strauss lecture, and talking about truth and truthiness, which we're really wondering exactly what that's going to be about. Okay, thank you.
I'm peripatetic, as they say. I like to walk around a lot. Can you hear me? Is that even close to? Maybe that's high. How about now? Is that better? Better? Worse? It's okay. Can you hear me? Can you hear me in the back? All right. Thank you, Dr. Wood. That was really great. I've certainly enjoyed my visit here. Too brief, but it was great to see some old friends, make some new friends. Thanks so much for hosting. Thanks to the Strauss-Friedlander family. Thanks to the dean for making the effort to come by. Really appreciate it. I have no disclosures. Doug already mentioned the links between the University of Chicago and the University of Washington through the Strauss family. And it's always a highlight of our annual department's academic year to host the Strauss lecture. And so it's a particular thrill for me to do it here. All right, so when you go to a university, and we heard about this preparation H stuff, you know, you walk around Harvard and you see the Harvard and truth on it. If you walk around the University of Chicago, you see the crest there that says in Latin, let knowledge grow from more to more, so be human life enriched. And at the University of Washington, it's all about enlightenment. Everywhere you go, we learn about knowledge at universities, and we learn about truth at universities. So what is this thing called? What is knowledge and what is truth? How do we know what to believe? Epistemology is the branch of philosophy that deals with the nature of knowledge, of belief. I am not a philosopher, but I looked it up on Wikipedia, and I found out that that knowledge, as defined by Plato, lies somewhere between things that are things that we believe and things that are objectively true. So Plato said that there are truths out there in the world, sort of like anticipating CSI. The truth is out there. Then there are things that humans believe, and someplace there's an overlap there. And in the overlap between truth and beliefs is what we call knowledge. What is truthiness? So the American philosopher Stephen Colbert, on the very first Colbert report, had a segment called The Word, where he coined the term truthiness to refer to a seemingly truthful quality that's claimed for something, not because of supporting facts or evidence, but because of a feeling that it's true or a desire for it to be true. So truthiness is that stuff that you feel in the gut, stuff in books, and we believe it's true because we want it to be true, but that doesn't necessarily make it true. So what I'm going to talk to you about this afternoon is evidence and what we do with it as surgeons, the challenge of understanding cognitive bias and how we compensate for our cognitive biases in making good clinical decisions, address the topic of or introduce the concept of tacit knowledge and this thing called clinical judgment, and talk about the implications to educate surgeons. So from the starting point, let's say that the practice of surgery reflects an accumulated wisdom that mixes fact, opinion, and magical thinking in unknown proportions. I think we can get our heads wrapped around that. That's not too controversial. So how do you learn to be a surgeon when you don't know whether what you're being taught is actually true or not? How do you tell people? We heard today so many different subjects were coming up, or new knowledge was emerging. That means it's being replaced by old knowledge is being replaced, new knowledge is coming on board. You know, it's always said half of what you learn in medical school isn't true. We don't know which half, you know, that old saying there. So how do you learn to be a surgeon when you don't know if you're being taught the truth? Let's run through a typical silly example. You're called at 10 o'clock at night to evaluate a postoperative fever the second night after an open colectomy. Symptoms: there's diminished breath sounds at the left base on your physical exam. Otherwise, your exam is unremarkable. How do you figure out what the diagnoses are? Where are the residents? What's the diagnosis? Why does this patient have fever? You go to any surgical textbook that you want, you look it up, and you'll find a statement like this: that fever within 48 hours after surgery is usually caused by atelectasis. Re-expansion of the lungs causes body temperature to return to normal. Atelectasis is responsible for over 90% of febrile episodes. So what do? You might get a chest x-ray, you order chest PT night long, give them a blow box, they suck on the blow box. Lo and behold, by the morning, the febrile episode is gone. Your chief resident comes in and says, good job, you cured the atelectasis, the fever is gone, and the diagnosis and your intervention have been validated, reinforcing your understanding and your belief in atelectasis as a cause of early postoperative fever. But you know that's not true. We just say that as if it's true. The relationship between atelectasis and fever is entirely unsupported by any clinical or experimental evidence. There is nothing true. There is no animal model where atelectasis produces fever. You can drop a lung when you're putting in a central line and get total atelectasis, and fever isn't a part of that syndrome. And in fact, if you do the study and you look for the incidence of postoperative atelectasis in cardiac patients, this has been done with and without fever, you find out that the incidence of radiographic atelectasis with patients with and without fever. But you only get that chest x-ray on the patients who had the fever, so you make this faulty association. So this idea sort of gets perpetuated all the time. Maybe it's not such an interesting example of it, but it's funny to see how that concept is so ingrained in everything that we were taught for such a long period of time. I have no idea what the fevers are due to. If we want to call it atelectasis, it doesn't bother me at all. It's not a big deal or not. These persistent things. So I went down this deep rabbit hole to try to figure out who said that atelectasis causes fever. Why do we believe that? How did that idea come into being? Does anybody know the answer to this? It took me years to go down the rabbit hole and figure it out. Anybody know? So it turns out it was Whipple. So the very first study that linked atelectasis to fever was by Whipple in 1918, in the early years after the introduction of X-rays into clinical medicine. Whipple said he noted unusual chest radiograph findings in patients with unexplained fever on postoperative day 1 and 2. So you want to disagree with Whipple? Whipple said it in 1918, and everybody believed it for the next 100 years. So this is an example of truth by consensus. It's reinforced by powerful thought leaders because and it's caused probably a positive behavioral imprinting over generations. You get out of bed, you see the patient, go examine them, make sure they don't have a serious cause of postoperative fever, and then we attribute it up to this mysterious thing called atelectasis, which doesn't really matter very much. But how are we supposed to figure out what's really true? That's an example of something that's sort of truthy. It's not true at all. But how do we figure out scientific method? Scientific method relies on observable, measurable evidence. We often take a reductionist experimental approach. That ideas can be traced back to Descartes. We think that science involves a refutable hypothesis. The idea that the philosopher Karl Popper used to talk about was falsifiability, that distinguishes science from religion. That science, for something to be a scientific idea, it has to be false. And we think of science as an iterative process that gets better and better at predicting what we think is going to happen in the future. There's a branch of philosophy called positivism, which essentially says that the only path to truth is through science. The only way you can know something is for science to prove it. The version that we live all the time with in clinical medicine is the idea of evidence-based medicine. That's the scientific method and positivism in action, where we believe that the best clinical decisions are by science, where we try to get the best available information rather than opinion or anecdote or just our hunch, to try to reinforce why we're making a clinical recommendation for a patient or choosing one therapy versus another. And we all learn the evidence pyramid, where randomized controlled trials are at the top of that. We like to look for meta-analyses of randomized trials and systematic reviews to try to reinforce the power of that evidence. This was a concept that really took off in the 1990s. Was introduced by folks up at McMaster, by Gordon Guyatt and others. And, of course, not that we weren't practicing science-based medicine before that time, but that's when the term really took off. But is the practice of evidence-based medicine evidence-based? Is there evidence to support that rigorous adoption of EBM principles actually improves clinical decision-making and outcomes? It's actually surprisingly hard to prove that philosophy or that approach leads to clinical decisions or outcomes. You would think it does. It stands to reason. But there's since the introduction of the concept, it's always bugged people. There's been these detractors of it saying it's not telling the whole story about what's going on, because many of the fundamental concepts underlying evidence-based medicine might not be true. Is it true that objective parameters are inherently superior to subjective ones? The only things that matter are the things that you can measure. or, those just, flip it around. If the only thing that matters can be measured, only thing measured, not everything can be measured matters. What about all the circumstances where we don't have data or we can't get data? Does that matter, or do we just ignore the aspects of the clinical situation for which we have no data and just focus on, where the light is rather than where we drop the keys kind of thing? Is there only one relevant question in any given clinical situation? Is there only one way to ask that clinical question at a given point in? And how do you handle patients? This came up earlier today. How do you handle decision making in patients who don't fit the average? How much weight do you afford which types of evidence and when? And what is this thing called clinical judgment, where you can use clinical judgment to override the so-called evidence and make a decision that apparently isn't according to evidence-based practice, but clinical judgment says that you should be able to interpret it in a different way. How does that work? So evidence-based medicine is conceptually very attractive, and we sort of feel like it ought to be the right way to think about clinical decisions. But when you apply it, it's maddening how often it seems to fall short, and it gets confusing as to how we're supposed to think about it. This is the case where this will be a good Patch Dellinger case. This is the case that got me thinking about this talk. It was maybe 15 years ago now. We had a patient that was transferred to our ICU with necrotizing pancreatitis, and the patient had been transferred on so-called prophylactic antibiotics to try to prevent the development of infected pancreatic was more often lethal. So the idea of starting a patient early on antibiotics when they had severe pancreatitis to prevent the development of infection and death was a standard practice. And it's been looked at in many prospective randomized controlled trials. So I asked the question, actually, is this evidence-based practice? We started a discussion with the health staff. And so what do you do when you're trying to practice the evidence-based medicine approach? You're supposed to ask the question, prophylactic antibiotics be given to patients with acute necrotizing pancreatitis to prevent infection and death? Find the evidence. Is there any good quality evidence for this? You appraise and synthesize the evidence, and then you're supposed to apply the evidence. It sounds great. So it turns out there were many prospective randomized controlled trials of that exact question. And in fact, there were many systematic reviews and meta-analyses. Now, you're sitting there in the ICU and you're saying, is this an evidence-based practice or not? You don't have time to go back to every single randomized. So we rely on these systematic reviews and these Cochrane meta-analyses to sort of give us a sense as to what does the literature say and what's our practice. So we said, let's go find a good meta-analysis. So we went and looked at a few meta-analyses, and we found, several of them that we looked at seemed to say it was consistent. Yes, we should be giving prophylactic antibiotics to prevent infection in pancreatic necrosis. It does seem to be reducing death. It does seem to be reducing the development of infection. It seemed to be an evidence-based practice. The more we kept doing the literature review, we found that there weren't just 3 meta-analyses and 3 systematic reviews. It turns out there were like 20 of them. And when you looked at all of them, you're not meant to be able to read all of this. It turns out that you could find as many Cochrane reviews and meta-analyses and systematic reviews that came to the opposite conclusion, studying the exact same clinical trials. And depending upon how the author write about those clinical trials or what inclusion criteria they were using to include or exclude a trial from consideration, they could come to entirely opposite conclusions. So if you were keeping tally, there were 7 meta-analyses that said, no, you shouldn't give prophylactic antibiotics to pancreatitis patients. There were 6 meta-analyses that said, yes, you should. And there were 2 meta-analyses that said, maybe we can't tell. So what are you supposed to do with that? What's going on there? How come we couldn't decision? It turns out that concept, that different meta-analyses of the same topic can come to opposite conclusions, or widely is not confined to the antibiotics in pancreatitis. It turns out to be a very common theme. And there is this article came out last year in the British Journal of Surgery, talking about high variability in results and the methodologic quality among overlapping systematic reviews on the same topics in surgery, finding that depending upon which, and this happened to look at, I think this was looking at percutaneous interventions versus coronary artery bypass on which was better. And depending upon which author you wanted to read, you could find a systematic review to support whatever viewpoint you wanted to espouse. So why is it so hard to apply evidence-based practice, rigorously in so many of these different circumstances? Well, it turns out that what we're trying to look for differences between in treatment A versus treatment B is often dealing with the problem of the small effect size. And so what ends up happening when you're studying with a small effect size is you've got to do a really good series of controls to make sure you're not sort of losing the effect or missing the positive effect. So you have very strict entry criteria. And it turns out that the more rigorously you apply the entry criteria and the higher quality of the science that goes into it, the less applicable it gets to the real world situation. So you have this situation who you're trying to think about how to treat wouldn't qualify for the trial in the first place, wouldn't qualify for the study. So you have this problem of how do you uncover a real and meaningful effect of a new treatment when you're dealing with a small effect size. This isn't necessarily solved by meta-analyses. The other problem that we have is that we don't understand when things stop being true. And we heard today of, I think some of the lung cancer talk about a study from the 1980s. And we sort of came to the conclusion after all the discussion that was presented today that probably that study from 1988 or whenever it was is no longer true. But when did it stop becoming true? If you look at a surgical journal or any medical journal from 20 or 30 years ago, you read the table of contents, you look and see most of the stuff that's in there isn't relevant to our practice anymore because everything seems to have changed. But so when does that happen? When does something stop being true? What's the half-life of truth? But let's frame this a different way. Let's say that we didn't have the problem of small effect size, and we knew that we have evidence that is incontrovertible and absolutely, supported, by our best scientific evidence. Do we actually follow the evidence as surgeons? This was a study that was done where they surveyed the French Society of Digestive Surgery, basically the French equivalent of the and they polled these expert academic French surgeons on 13 practices in GI surgery, things that were well established with a very strong evidence base for it. Routine use of nasogastric tubes after GI surgery, preoperative chest x-rays, these sorts of practices where there's absolutely no controversy in the field, that evidence only shows and supports it one way. And it turns out that only about half were actually done were actually applied in practice. So even when the evidence was there, the evidence-based practice was only followed about half the time by the experts. So you can see that there's something going on there where even in the face of clear evidence, even the experts don't necessarily follow it. So we looked at this and we said, well, they're French. What do they know? They're going to do this again. We're going to study it with American surgeons. And we looked at the exact same questions with a group with faculty at University of South Florida, University of Chicago, senior residents, junior residents, attendings, and it turns out we weren't any better. That the practices that we actually implemented, despite the availability of the evidence, didn't change practice even in good academic centers. So evidently, we're not very good at following evidence. Why is that? Why aren't we good at following evidence-based practices? Well, maybe we can't keep up with all the changes. We just can't read that much and follow it. Maybe we don't believe the evidence. We have a reason to say, that's not really how I see it. Maybe we reject evidence that we don't like. But it's interesting to see, I don't have the answer for this, but we are very slow to reject things that we've brought up doing. It's very hard to stop doing things. These time-honored practices, the way you were taught by your chief resident, who was taught by their chief resident, or the chief of the service. It's hard to make that stuff go away. And yet, so even despite all the evidence, we just will hang on to the things that we were trained to do. And on the flip side is when something cool comes along, we're really fast about jumping on that bandwagon. Look how laparoscopic surgery took off, or robotic surgery now took off, despite really very little evidence supporting the practices as leading to better outcomes. So we'll leap on something even before the evidence is there, but we won't reject a practice that we like, even in the face of controversial or contradictory evidence. So, what's going on? I'm not sure. Gladwell talks about the stickiness of a good idea. When we started doing laparoscopy for intra-abdominal mastectomy, most surgeons who were skeptical initially, as soon as they stuck the scope in, said, "Oh yeah, this is going to be better," and the idea just stuck. When there's a lot of other practices over the years that have gotten introduced in, say, GI surgery practice that you knew never were going to take hold, like those metal bands around the esophageal hiatus to stop reflux. Those links procedures. You knew that was never going to take hold. And then the other thing is that we are very good at believing what Adam Seafood calls bioplausibility arguments. The idea that if we can come up with a rational explanation for why we think our approach is better, we tend to believe that. It doesn't make it true, but it feels like it's plausible. So the idea that bioplausibility should trump evidence is questionable. This is a real problem for surgical science and for evidence-based surgery, because it turns out that randomized controlled trials make up less than 5% of the surgical literature. Most of what we read has nothing to do with the highest levels of evidence. And many surgical conditions are simply not amenable to randomized controlled trials. We heard about that in a couple of different talks earlier today. There's a lot of barriers to running good surgical randomized trials. In fact, when somebody does run a really good randomized surgical trial, it's all the more notable because they managed to pull it off. It's really hard to do. Problems with randomization, there's problems with recruitment, there's problems with blinding, there's problems with the disease incidence, and how do you find enough of the condition that you want to study to be able to actually do the trial in the first place. In surgery, we have challenges around standardization of technique. In some conditions, there's probably a lot of margin for error in terms of the surgical technique. But particularly when you're dealing with surgical in a more complex disease, surgical technique matters. And it's really hard to say that the operation I do is the same as the operation that all the other surgeons are doing in this randomized controlled trial. Challenges of ethics and equipoise. And one thing that I think is not talked about enough is the problem of the rapid technology cycle, which is that if you're going to do a really good study in surgery, the results are going to be obsolete before you can complete it. You were doing 3 years ago is not what you're going to be doing 3 years from now. So we can never catch up on this, on this race. So it's really hard to get the evidence that's going to be meaningful at a single point in time. The challenge of generalizability of the results of surgical trials is particularly difficult. How do you take the results of what you read in the journal and say, this really works in my practice here under these local conditions? That's the external validation that's necessary. It's hard because the patients are very heterogeneous. The surgical conditions are often very heterogeneous. There's differences between institutions and the skills and experiences and trainings of surgeons. It's different than other fields of medicine, where it's a little easier to standardize, how this pill happens or this infusion happens. Doesn't matter a whole lot of technique of how you hand the pill to the patient. There's a little more ability for that to be standardized than for big operations. So this means that in surgery, we know that experience and techniques matter, but we never really know how much and in what situations and how it's going to impact the generalizability of results. So for all of these reasons, surgeons are forced to rely on lower quality trials, cohort series, case-controlled studies, and all of this work. And the lack of good randomized controlled trials makes that problem that I alluded to earlier of not really being able to interpret the systematic reviews of the evidence because the inputs are bad to begin with. The other problem is that some of what we read and some of the science that you read isn't actually true. Just because it's published, doesn't make it true. There's good evidence that you should question what's published. Good evidence to question the evidence. If you want to have a little Schadenfreude or whatever, you go to retractionwatch.com and see all of the examples of fraud and plagiarism and retractions that happen when things can't turn out to be have questionable results. This challenge of the reproducibility crisis that we have, where you have a scientific study that's never been replicated because either nobody's tried or people can't replicate that. That's a huge problem, particularly in the social sciences, but a huge issue throughout the biomedical literature. It was estimated, there was a study I read a couple of years ago where the in-house scientists at Bay to validate some published work on, I think they looked at a bunch of drug discovery, basic science papers, and their in-house scientists tried to reproduce the findings. And I think they only were able to reproduce a third of the drug discovery research that had been published. So they new scientists trying the exact same methods couldn't reproduce what had been published, often in very high impact journals. Lots of other things with how we know what's true that's out there. Anything can get published these days, and particularly in the world of predatory journals, et cetera. There's a lot of misinformation and outright fraud out there. Most people know this paper at this point in time from PLOS One by Johnny Unitas, who's become very controversial in the post-COVID world for his. But this is actually a mind-blowing article to read, and it highlights a lot of the themes that I'm talking about, but does it in a much more rigorous way, where he says sort of pretty dramatically that most claimed research findings are probably false because of the challenges of pervasive false positives in the literature, the small studies, the inappropriate use of statistics, the lack of confirmatory studies, and a lot of data manipulation and overfitting, often innocent, nefariously, but it's just the way science tends to get conducted. So there's a lot of false work that's in the literature. So you need to be careful about what you read and how you interpret it. The literature is highly biased. We know this. Michael Eisen, who was one of the founders of PLS, of the Public Library of Science, who's I think he's at Cal Berkeley, he's a biologist, wrote a great editorial about all the flaws in the peer review system, but lots of ways that that the literature is biased. The classic one is the positive outcome bias, where you're much more likely to get your paper published or your grant funded with positive findings than you are if you submit something with negative findings. The time lag bias is very interesting. If a journal editor is doing their job, they would be willing to consider negative studies, but they usually won't a negative study before the first positive study is done. The negative study is usually not very interesting, but if a positive study result gets supported and then somebody can't reproduce it, if they're doing their job, they'll publish that negative study. But it's often after several years of the positive study being out there. So the positive study tends to get cited more often, and it's hard to get that idea stamped out over time. And lots of other flaws in the system that we don't have time to go into. Need to do more science? Do we need to just get better and better at everything, get more data? More and better evidence is not necessarily the answer for the challenges that I'm talking about. I mean, we talk about big data and how exciting the use of big data is in lots of different contexts, a few of them just listed there. The problem is not so much how we get large amounts of data, but how do we understand and interact as individuals or as an intellectual community with that evidence. Nate Silver, who wrote a wonderful book called The Signal and the Noise, he was a math major at the University of Chicago, this is a great book about this challenge of too much information. This is a line from it. Information is no longer a scarce commodity. We have more of it than we know what to do with. We perceive it selectively, subjectively, and without much self-regard for the distortions that this causes. So what kinds of distortions are we talking about? So the idea that truth is a fundamentally questionable tenet. And we've seen this movie. This movie won best foreign language film, I think, 1959, the year I was born. It's called Rashomon. It's a great samurai movie by Akira Kurosawa with the great Toshiro Mifune in the lead role. And I think Rashomon means in the woods or in a grove or something like that. And it's a story of a murder that takes place in a grove. And there are 4 people who are involved in the murder that happens. And the film consists of 4 retellings of what happened by the 4 people who interacted in that, who were participants in this murder. And depending upon who was telling the storyteller put themselves in the best possible light, and the interpretation of the events came out entirely different. So there were facts, a murder occurred, but to selectively assembled the ideas and what happened and what the motivations were, an entirely different story could get told about what happened. So that's, in psychology circles, that's known as the Rashomon effect. The idea is that we listen to stories. For surgeons, that's M&M conference, right? M&M conference is the example of Rashomon effect, is right. The resident gets up and says, well, we did the thing leaked and all that, this happened, the patient went to the ICU. And then the attending says, well, that's not really what happened. What really happened was, this is what I was saying. And the anesthesiologist says, well, from our point of view, this is what happened. Got their perspective on the exact same event. So what's the truth? It's somewhere in there, but it's hard to know exactly what that is. So that's the concept of cognitive bias. That's how there are these ideas that are out there, these facts that are out there, but they don't exist in isolation of a human's ability to interpret and process and selectively weigh them. So we filter all of what we know through our imperfect lenses of human perception. You know, economists know, pollsters know this. The whole field of behavior wins all these Nobel Prizes from the University of Chicago is based on this idea that people don't behave rationally, that with all the different facts and odds and all that sort of stuff, we don't make rational decisions. So how do you nudge people towards certain types of behaviors if they're not going to make scientifically based? This is inherent in how we are as humans. We make choices with very limited rationality, and this undermines our ability to make true evidence-based decisions. Of cognitive bias that you can think of. There's the bandwagon effect, jumping on to robotic surgery and robotic surgery for everything is a bandwagon phenomenon. There's the effect that's called déformation professionnelle, which is that you look at a situation and your opinion is shaped by what you do. So you look at a situation as a surgeon, or you look at a situation as an anesthesiologist, or you look at it as a dean, or you look at a situation as a policy at it as a, God forbid, a patient. So there's lots of different perspectives on this. So you look through it through the eyes of who you are and what you do. So this was an example from earlier today. We were talking about the surgical treatment of painful large duct chronic pancreatitis and saying, should we do surgery to try to decompress that duct and relieve pain? Should we do endoscopy to try to decompress that duct and relieve pain? And we know that there are these prospective randomized trials that are done comparing the two results. Surgery always comes out as controlled trials. But if you look at the New England Journal of Medicine, and this was subsequently confirmed in a follow-up study as well, again, showing that surgery first was better, more effective, safer, better outcomes. What does it say in the editorial written by an endoscopist? It says, although surgery has now been shown to be superior for long-term pain control in 2 randomized controlled studies, many patients are anxious to avoid surgery if at all possible. Although endoscopic treatment's not without perceive it as safer and simpler. Endoscopic therapy remains a reasonable treatment option depending upon patient preferences because patients can always undergo subsequent surgery. That's not what the trial showed, right? But that's the interpretation. And so surgeons would chuckle, yeah, endoscopists. But it's not crazy. It's a very reasonable interpretation of like how people would react to this. And it's hard to argue with that, even though the facts don't really support it, but it's a very reasonable interpretation. So, there's lots of cognitive bias at work, and I just displayed one. I'm a surgeon. I do pancreatic operating on the pancreas. I want to do that case. So I'm biased to think one thing about this, and the endoscopist is biased to think something else. So we have lots of things. You search the literature for things that support your preconceived ideas. How do you frame the question for the patient? You don't really want to have an operation. Let's try endoscopy first. You can make decisions based on how you pose the situation. Surgeons are really susceptible to this problem. We like to think of ourselves as objective and all this, but we are very vulnerable of what we do to the problem of cognitive bias. We are very influenced by dogma. We are very influenced by our mentors. We have great respect for hierarchies. We sort of grow up with this idea of the importance of, nobody questioned Whipple, right? So we grow up with this respect for how sort of decisions get made and the value of experience, et cetera. We love our stories. Surgeons love to happen. We tell stories at M&M, we tell stories at the scrub sink, et cetera. We are very good at anecdotal rationalization. You know, whatever didn't work this time, I'm going to do the opposite next time until it stops working, then I'll change my practice again. Surgeons, we love linear causality because we're very action oriented. And it's one of our greatest strengths is that we have a deep connection between what we do and the decisions that we make to the patient. But we tend to apply that linear causality probably in situations that are far more complex than that. And we've got the same vested economic interests. We hate it when non-surgeons encroach on our turf, or when the proceduralists come along and show us that they can do things better with little wires and that sort of thing. We hate that, right? So we're really susceptible to those biases. So what do we do about that? Is there any way that we can work to repair our cognitive biases and make better, more rational decisions? Well, some of this we do already, and we don't even realize that we're doing it. If you talk to cognitive psychologists, one of the things that they default to as a really good example of a so-called cognitive repair is the ABCs of trauma surgery, right? That's a really good example of a heuristic, a rule of thumb that allows you to make better clinical judgments and not be distracted by things that shouldn't be getting in the way of the decision, to try to make sure you do the same thing every time and that you prioritize what's most important in a situation right now. In fact, it's very interesting to see how that heuristic can be applied in situations. Any of the senior surgeons in the room who have given oral board exams know this, that whenever you ask any question to any candidate who's taking their oral board exams, and you say, I've got an 18-year-old college student who's got right lower quadrant pain and nausea, and they're validated focal tenderness down there. The candidate is so nervous, they say, well, first I would check their airway and make sure that they're breathing and check their circulation. Wait, it's appendicitis we're talking about. But when you get nervous and you're sort of scared and all that, what do? You default to it. You know, you default to a way of thinking about this situation. And that's a heuristic. That's a good example of a cognitive repair. Other examples of it are from some of the practices that we routinely do in surgical oncology and other areas where you have multidisciplinary conferences. You get more than one perspective on that. And if you're doing a really good job at your multi-disc conferences, you even have patient advocates. You might actually have, you know, somebody from the OR, somebody who's looking at resources and other sorts of things. You might have your nurses there. You get different viewpoints. Decision is going to be for this patient and that family. So we do that as ways of trying to buffer some of our flawed thinking as single individuals. We also see a lot of these risk calculators around and these decision support tools. And for anything that you're interested in, you can probably find a guideline that's been written by some society somewhere. We heard about a lot of guidelines today about how we approach different complex situations, what you do, the arrows about what you're supposed to do in every situation. So there's a lot of these things that are out there that are supposed to help us make better decisions. They're good, they're helpful, and they're very appealing because they simplify things that feel really complicated. But you have to use them with caution. You have to remember, and particularly in surgery, that most of the guidelines and risk calculators that you are finding in chapter articles are supported by only low quality data. And the guidelines themselves reflect the biases of the people who wrote those guidelines. The challenge of coming up with what's really a continuum of disease and trying to force it into discrete categories, like do this if it's the lesion's less than 2 centimeters, but do that if it's greater than 2 centimeters, as if there was something magical about that cutoff there. So not understanding the gradations of disease there. These risk calculators can often be flawed because they aren't validated or updated in time. And in any given situation, there are so many different guidelines that might apply to a given patient. It's hard to figure out which one you want to use. I think it's been estimated that the average patient that walks into the emergency department is something like 14 different aspects that guidelines might be relevant for. So which ones do you pull out when, and how do you follow that? And I think one of the challenges with the guidelines is this we sort of fool ourselves because we get a little mathematical precision. You get your risk calculator and figure out what the odds are of mortality in this situation, and you get it down to the 10th of a decimal point, and it creates this illusion of mathematical certainty that substitutes for really a lot of uncertainty. Trish Greenhold had this great quote: "As the population ages and the prevalence of chronic degenerative diseases, patient with a single condition that maps unproblematically to a single evidence-based guideline is a rarity." So guidelines are often less evidence-based than apparent. Usually guidelines are consensus-based, sometimes known as eminence-based medicine rather than evidence-based medicine. And even the folks at McMaster who introduced the tenets of evidence-based medicine have seen this as a problem and something that needs to be updated and rethought for the sake of time, I won't go into some of the details there. But how do we, as individual surgeons, like use these risk assessments to make decisions for individuals? Because we can read the literature and be as theoretical as you want to be about it in a setting like this, but then you go to your clinic and then Mrs. Nifnick is there, and you got to figure out, what am I supposed to do for Mrs. Nifnick? So how are you supposed to handle that situation? So let's talk about that. An 80-year-old patient, let's imagine, who has a clearly resectable, biopsy-proven adenocarcinoma in the pancreatic. You're going to do a Whipple on that patient. Typical patient will show up in surgical oncology clinic. How do you decide if you're going to do a Whipple on an 80-year-old, right? That's a pretty big decision. So what are you going to do? The patient wants to know, what are my chances, doc? So you get your risk calculator and you figure out what's the risk of mortality in this operation in the elderly. You can say, what's the cancer-specific survival that I'm going to get? I can look at the ACS NISQIP risk calculator and come up with some numbers. You can come up with any odds that you want. The odds sitting in front of you. What do you do with those odds? How does that inform your decision? And do we all actually agree on what you're supposed to do with that? What matters in that situation? So let's say you calculated out that the perioperative mortality for this 80-year-old who is in otherwise great shape and has a cancer of the pancreatic head, you're going to do a Whipple, 2% mortality rate. So you're going to do a Whipple in that situation? Ask me and say yes, right? Go. Now, how about if the risk calculator came back and said there was a 20% risk of mortality? Everybody shakes their head no, says they're not going to do it. How about if it calculates at 8%? And you start to get these intermittent, maybe I would do it. Maybe some people would do it, some people wouldn't do it. How do you decide what's right in there? What is that stuff that makes you decide in this patient with an 8% calculated risk of mortality or a 5% of risk of mortality, I'm going to do the operation, but what's happening there? How do you make those decisions? Now, what if the patient was 92? What if the vein had to be resected? How about if it was a pre-malignant lesion? These are issues that come up in real time every day. What evidence do you use to inform that decision? And how do you teach somebody how to make that decision in an evidence-based way? And how do you get the patients to understand what's involved and what's happening? A gap. It's always really messy if you're being honest. So there's problem with taking the data and translating it to the situation with Mrs. Nifnick, because you never really know how your results are going to compare, what the specific anatomic circumstances are. This is that problem of the average patient. What are the patient's value systems? What's going on, who's taking care of them? This stuff isn't the stuff that you can calculate, right? But it turns out that that's a lot of what we actually have to do. I've given this talk before and everybody says, well, baseball was the same way. You can play a baseball game and the coaches will tell you about how what they want to do in this situation. That's a bunting situation, but the coaches don't know, because if you can measure it and you can get the math at it, you can mathematically go at it and come up with a better strategic decision to win the game of baseball. And that's the whole Moneyball, Billy Bean kind of stuff that you probably saw the Brad Pitt movie about. So is surgical saber medicine? Is there a way that we could actually math our way into better decisions? I don't know about that. I think we could probably math our way into better technical skills training to get better at, I would love for somebody to tell me that the angle of my approach to a stitch was wrong and that I could stitch it better. We heard about the ergonomics talk today. Probably a lot of math in that would be really interesting and cool to do. But that's not necessarily what's going to help us in making the best decision for Mrs. Nifnick's care, because it's hard. That's the stuff that's hard to measure. So don't misunderstand me. Evidence matters. Walk away from this talk sometimes and say, I don't believe in evidence. I do believe in evidence. I do believe in data. It's a very important framework. And big data is incredibly exciting. I personally love the idea of surgical sabermetrics. But the point is that evidence-based medicine in its current form is not what you need to necessarily learn how to be a good surgeon. It's not what's needed for good care. And this is where this notion of tacit knowledge comes in, that I think is a really important and underestimated concept that we need to get back to. Michael Polanyi's concept was actually a mathematician who became disillusioned with the idea that science was the pathway to truth. And he introduced the concept of tacit knowledge and understanding of how we personally interact with facts, how we personally interact with information. The idea of knowing how to do something without being able to articulate how you do it or how you came to know how to do it. Tacit knowledge is what you learn locally. It's when you learn how to, anybody know how to ride a bicycle? You know how to ride a bicycle here in Seattle? What book did you read? You didn't read a book to learn how to ride a bicycle. You know how to build a bicycle. But somehow we can ride a bicycle even though we never read a book. We were never formally taught, right? So what happened? You know, somebody ran behind you and then you worked on it and you fell a couple of times, or somebody caught you before you could fall, and somehow something clicked in your brain and you learned how to ride the bicycle. It's tacit knowledge. That's stuff that's gained locally, that you can't say how you learned it, but somehow you learned how to do it. It's not explicit knowledge, it's not facts, but it's equally important forms of knowledge. And that's what underlies this, this is what these emergent forms of knowledge are. This is what Gestalt is all about. This is how an experienced clinician can read the meaning between the story that the patient is telling you, the words, figure out what the patient's really saying, but you can't get it on an epic, EMR checklist, vomiting, no, pain, yes. It's all of that sort of stuff. That's tacit knowledge. The point is that elusive concept of clinical judgment, it blends explicit and tacit forms of knowledge. Obviously, you have to know something. You have to have a series of facts. But if that's all you have, you don't have clinical judgment. And if all you have is Gestalt, you don't have the facts as well. So somewhere there in between explicit and tacit forms of knowledge is this special sauce of what we call clinical judgment. But we don't really know what it is or how to measure it. But like Potter Stewart would say, we know it when we see it. We all know what clinical judgment means, but we don't know how you get it. And we don't know how to measure when people acquire it. So that's these uniquely humanistic elements that I don't think AI is going to. Most efforts at trying to math and computer our way into better clinical decisions, Watson Health and all that, they've all gone under because it turns out it's not, it doesn't really work. So daily clinical practice involves hundreds of decisions that require varying proportions of explicit and tacit knowledge. And evidence-based medicine only deals with the part that's more on the explicit side, the stuff that has a big effect and the stuff that's amenable to those randomized controlled trials, where much of what we do on surgery is really experience-based. And, we have to stop beating ourselves up, somehow not good scientists or something. That's the reality of where surgery is all in that side of experience-based medicine. And I think I can live with that. But we do have to improve evidence-based medicine. We have to make this evidence more understandable for patients so that we can sort of process how we're thinking about it and get the patients to think about what matters to them and make evidence-informed decisions rather than evidence-based decisions, trying to avoid these rigid algorithms and that sort of thing. We have to acknowledge more the all of our knowledge gaps, all of our biases, and this is a real challenge that we face. The implications for surgical education are pretty profound. The curriculum is more than the facts, and yet all we tend to do is test about facts, as if you can learn to be a surgeon based on multiple choice questions. We have to sort of re-highlight the importance of experiential learning, particularly for surgical trainees, to give them that opportunity for safe struggle, to be able to ride the bicycle with somebody, not letting you fall off, but letting you make some mistakes along the way until you get the hang of it. That image is a really important one. for how residents emerge to independence, and we don't pay enough attention to that. That's going to require new assessment frameworks, and it's going to require us relearning how do we assess how surgeons progress, particularly through our own imperfections and biases. In many respects, I would say that that managing uncertainty in the softer side is what I would call the seventh core competency. How do you make decisions when you have incomplete information? How good are you at recognizing the cognitive bias that's maybe distorting the clinical decision that's at hand? How can you limit your overconfidence in what you think you know and still be able to make a clinical decision as a surgeon? Nobody wants to, I don't know, the data is. You got to decide, you got to operate not a confident. You have to be able to make a decision in the face of all that uncertainty. So I think there's a lot that we have to learn about how to teach and evaluate how we approach uncertainty. So let me summarize and just say that there will always be a fuzzy interplay between truth and truthiness in surgery. That's inevitable because evidence is elusive, it's tenuous, and it's subject to bias. Evidence-based medicine isn't all that we talk about. It incompletely accounts for the complexity, particularly of surgical decisions, the incompleteness of our evidence base, the role of uncertainty, and the particular relevance of tacit skills and tacit forms of knowledge to surgical care. So clinical judgment emerges as we gain knowledge and experience. One final quote, Enrico Fermi, who was a Nobel laureate winning physicist at the University of Chicago for splitting the atom underneath the football stadium, or in the school, had this great quote. He was listening to a lecture by Niels Bohr, and he said to Niels Bohr, "Before I came here, I was confused about this subject. Having listened to your lecture, I'm still confused, but on a higher level." So I'm hoping you're still confused, but on a higher level. Doug, thanks very much for the invitation. Thanks to the Strauss family for the honor of being here. Thanks. Thanks for happy to answer questions.
If there's any questions, respond to questions. Also, very good. Very hard audience. Being in order to pick up the clinical volume about the United States demonstration system.
I mean, I think that first of all, I just get to ask the questions. I don't have to have any of the answers. So problem. I think you're pointing out a really good example of exactly what I'm talking about, which is that we would like to believe that we can science our way out of these critical issues. But what we're talking about are policy decisions. And by the way, how much did the pandemic illuminate how impossible it is to come up with a consensus on anything, let alone to make public policy based on that? We have a real problem in figuring out how to translate what we do and to translate the inherent uncertainties of science in. We have enough trouble trying to figure out ourselves what's true and not true, what the implications are for practice. So there's, despite that trial, despite all of the, look at the New England Journal colonoscopy paper that just came out, talk about controversy, looking at the facts and the outcome of a study by biases in terms of what you do. I mean, talk about controversy. I don't know what the answer is, but I think part of the answer is us recognizing that that's thematically a problem that runs throughout what we do. Andrew Miles has a great quote where he says that the scientific nature of medicine doesn't make medicine a science. So the fact that we're doing more and more quantitative stuff doesn't fundamentally change the nature of what we do, which is fundamentally not scientific.
That was an outstanding talk. Thank you. I am definitely confused on a higher level. Struggle with this every day in the care of surgical patients. And there's probably a few residents in the room who have realized that over the years, my answer to the question, what should we do, is more and more often, well, you know, there are no answers in surgery. There are only risks, benefits, and statistical likelihoods. And I wonder what tips you have, like me, when asked, what should we do? How do you reveal just the right amount of this internal dialogue that you have about truth and truthiness?
Yeah, it's a great question. I think the glib answer to that is we have to acknowledge that more than we currently do. I think there's an enormous pressure on us as educators to be certain about what we're talking about and to not be open to different viewpoints or to really question whether our own biases are in fact supportable. I think that we have to figure out ways to talk about these controversies a little bit better, understand whether there's a, this is what this aspect of this clinical situation can be informed by, but let's look at how this is similar to or different than what we know about that narrow area there. And, I think it's okay more often to say, do it. This is the judgment, and realize that's about as precise and important a thing. I mean, again, who teaches you how to ride the bicycle? They sort of know and they figured it out. And you have to at some point default to that experience, knowing that that's going to be imperfect too, but that might be the best integrator of all these uncertainties there, is years of experience. And we all know how to pick out whose judgment or whose hunches matter. But all the math in the world hasn't been able to come up with a better way of, the foot of the bed test. You walk into the patient's bed and say, how do you know that? I think we have to be better about talking about uncertainty.
Hi, I'm Dr. Mark Almaniel. I'm one of the interns, and it kind of relates to that question of, as an intern, I think any of the residents can agree, when we work with different attendings, each attending has a different way of not necessarily doing things, but different clinical judgments and different experiences. One attending would believe in Smith cone, one doesn't. They have a different way to position the table based on their experience with this certain procedure, others don't. And really the overall judgment is different from attending to attending. And my question is, what advice do you have for all of us navigating through our surgical training and coming out of it the other end?
Yeah, it's a great question. I think about this a lot. I think it's really important to read, this will sound crazy, like books, and to understand the general topic of what you're dealing with, so you learn context of what's going on. If you find yourself trying to figure out, should I do it the way attending A does it or the way attending B does it, you've missed what you should be reading about, which is, what do we understand about diverticulitis? What is this disease? What happens? How does it present? How does this patient represent the spectrum of that disease? And try to get that perspective. And then go along for the ride on all those other things. Don't worry about attending A does it this way, does it that way. Because if one does it one way and one does it the other way, it probably doesn't matter. And you'll figure it out after you've seen enough, after you sort of have enough exposure. It's one of the challenges, back in my day when were in the hospital all the time, you know, we saw a lot, and you couldn't say it was stupid to keep us there 120 hours a week, right? What were we doing? We weren't really, you know, we were getting tortured there, and we saw stuff, and somehow, you know, knowledge accumulated. So I think like what's really good is just to remind yourself that you're accumulating impressions and look for as many opportunities to see things as you can. You know, if you had any downtime, wander through the OR, peek over people's shoulders, get more experiences, talk amongst yourselves about what happened and all of that. But in your readings, on the classic stuff, you know, and don't focus on what the latest trial showed, because it probably is wrong. It's probably going to be disproven in a couple of years, or it's not as cool as everybody thinks it's going to be. Focus on the stuff that stood the test of time is what I think needs to happen. And then take the rest with a little bit of amusement, you know.
Thank you.